Double Jeopardy. This video is about two cases which presented to me after having two surgeries with double the trouble. Case 1 is about a patient who underwent ICL surgery but was given an injection during the surgery with resultant loss of vision and was operated again. Patient presented with mature cataract with history of silicone oil in the eye and no view of the fundus. This is how the patient presented with a mature cataract and the ICL. My first procedure was to remove the ICL. So I oriented the ICL in such a way that I could remove it from the limbal incision. And then I had planned to do the cataract surgery and not put an intraocular lens as patient was a high myope. And when I entered the eye after removing the silicone oil, to my surprise I found that the PVD had not been induced. So one can see that there were two large giant tears, one in the nasal quadrant and one in the temporal quadrant, with an area of needle perforation just above the optic disc. So the first step was to induce the PVD and clear the vitreous. This is the temporal edge of the GRT. It was having an attached or a attached retina only in the inferior quadrant. So I proceeded to remove all the vitreous membranes that were present so as to relax the retina and make it more mobile, so that when I inject the PFCL, it should not go under the retina, trying to create adequate space at the posterior pole. So meticulously trying to release as much as is possible before I do the next step. Then I removed the PFCL bubbles which had gone subretinal from the previous surgery. Having done that, I injected PFCL to stabilize the posterior pole and then proceeded anteriorly, releasing all the membranes. Once done, I did a localized retinectomy, joining the two giant retinal tears, as one can see from the diathermy marks. And then did an endolaser to all the areas of the retinal tears. The retina was attached, and having done that, I put in silicone oil. However, on around a month of follow-up, patient developed redetachment predominantly in the inferior quadrant with macular pucker. So I carefully removed these membranes, first getting an edge by using a pick and then removing it with the forceps. Then induced the ILM peeling by staining it with brilliant blue under the PFCL and trying to release or mobilize the inferior retina which had detached by using triamcinolone. Once having done that, I put in silicone oil after having got an attached retina and did more endolaser. I could get an attached retina and after removing of silicone oil, I have a follow-up of now about 18 months. It's an attached retina with 20/60 vision. Case 2 is about a patient who underwent routine cataract surgery with posterior capsule rent, but an IOL was placed. This IOL dislocated and the patient had already undergone a second surgery wherein a AC IOL was placed. But when patient presented to me, he had PFCL droplets in the AC with a pure view of the fundus. So I planned to remove the dislocated IOL, but when I entered the eye, I could see that the vitreous was all present and PFCL had been used without inducing the PVD and clearing the vitreous. So first was to clear the vitreous and remove the PFCL. Then I used a chandelier illumination, put a small bubble of PFCL to raise the dislocated IOL, and using bimanual handshake technique, oriented it such that I could remove it between the AC lens and the iris. Having done that, I cleared up all the bubbles that were present in the anterior chamber and in the vitreous. I was quite fortunate to have an attached retina. There were no tears. After examination, I closed the case. Learnings are complications have to be expected in any surgery, and surgeons should try to see that they mitigate the problem, accept the complication and avoid irrational procedures. Thank you.